Hi everybody, welcome to my channel. Let's talk more about wounds. This is a subject I could talk on for days. Let's talk about wounds in end of life and how we manage those. In end of life, when your body is beginning to shut down, your skin is also an organ and it will fail, and sometimes there will be skin breakdown that happens as your life is ending. So let's talk about that more. And if you like what you see here, then I ask you to like, subscribe, and follow for more. Just want to put it out there that nothing I say replaces the advice of an MD. These are all just my experiences, my opinion, and take what resonates with you and leave what doesn't, like the psychics say. Let's talk about wounds in end of life. When you are compromised and at the end of your life and things are beginning to wind down and organs are failing, your skin is an organ and it will fail too. And you have a lower threshold to break down and get a wound when you are at end of life. And they come on quickly. And our goals of care are different in hospice than they are in a more aggressive setting. Do we treat wounds in hospice? We absolutely treat wounds in hospice, and we love to see them healed just as much as any other healthcare realm. You know, we love to see wounds heal. It's impressive if it does. A lot of times though, in end of life, we aren't going to see those wounds heal. And so our goal becomes about comfort and about managing the wound care, and also pain, comfort, again, comfort. We want to make sure that our patient is not experiencing discomfort with their wound. A lot of times when wounds crop up in hospice, you know, stage 2 wounds are very tender. They have nerve endings. They have circulation. So sometimes those can be very painful when you're talking about a fresh wound, especially, you know, something that's open and irritated. You want to be watching drainage that could happen in wounds. I think I would like to talk about the types of infections that you can commonly see in wounds that might surprise you. So staph, methicillin-resistant Staphylococcus aureus. That is a common bacteria that you can see. That needs an antibiotic typically. A lot of people have MRSA. We have it in our nares. We're exposed to it. We have it on our skin. This is a very common infection. But anything that gets into a wound can become systemic and can create sepsis. So we do want to avoid infections in our people at end of life. Depending on where they're at in their death and dying process, we certainly don't want an infection to add to what's going on with their death and dying process. Something also that you can see is Pseudomonas. I will tell you that you will know it's Pseudomonas the second you open the bandage, because it will look like robin's egg blue or turquoise. It has a distinct color and a distinct odor. There's also something called Proteus mirabilis. This is something you can see in the urine. This is something you can see in a wound. It's not a nice one. It is definitely purulent, and you will know it if you ever see it. That is just some of the common ones that I have seen in wound care, but that Pseudomonas, you will know it when you see it. It is that turquoise color, and you'll wonder, why is this drainage this color? And that is what it is, and you will contact the doctor and they will get an antibiotic going. When we're doing wound care in hospice, we really are not looking to be super duper aggressive. We're not doing sharp debriding. We're not doing those things. I mean, I guess in an inpatient unit, they may have somebody that's doing those sorts of things for if it's a comfort related thing. But at end of life, our goal is more so to keep a patient comfortable. We will use things that will do light debriding, autolytic debriding, enzymatic debriding. We will use things that will do those. Honey is the most common thing that we use, and we use a lot of hydrogel. Those things are pretty gentle and they're pretty readily available for the most part. I mean, honey is not always available, but it is very popular and it is very effective. We use a lot of alginates, we use a lot of foams. I will say to you that if you are needing to change a foam dressing every day, the wound probably is not benefiting from the foam. However, if you're trying to pad an area such as a tailbone that's really bony, sometimes those foams, you know, they are getting changed every day, and it is what it is. But I will tell you that in hospice, what we're really looking to do is to prevent infection and to maintain comfort. So when you're going to do wound care for a hospice patient, you want to give that family a heads up so that they can administer a pain medication in any wound care. In any wound care where you know you're going to be manipulating the patient, moving them around, cleaning things, you probably want to medicate ahead of time. You want to give pain medication 30 minutes to an hour before you go to do wound care because it's uncomfortable. Sometimes it hurts when you're taking off the bandage. Sometimes it hurts when you're cleaning the wound. And it hurts them sometimes when you're moving their body and repositioning them to get to that wound. A lot of times wounds are in places where you're just not going to get to them easily. You want to clean the wound from inside of the wound bed to out, cleaning the skin around it last. We want to use things like skin prep to protect the skin from the tape that we're using, from the drainage, and from the medications that we're putting inside the wound bed. We want to protect the good skin and treat the skin that is damaged. So when we're treating wounds, we want to treat the wound and not get that stuff on the healthy tissue. That's really important in wound care, that you do a little bit of a barrier when you're doing that. Another thing that we do is we also have surgical wounds sometimes that we're taking care of, dehiscents or things that didn't heal inside but they healed outside, and now they have been reopened and they're healing by secondary intention. So sometimes we are doing other wounds. Sometimes people come on to hospice and we are taking care of a surgical wound that happened. Maybe they broke their hip and they have staples, maybe the wound dehisced. I have seen abscesses that grow from little sites. So there's a lot of different types of wounds that you can encounter. Pressure ulcers are the most common thing, but when you're talking about end of life, surgical wounds don't heal as fast either. The skin needs nutrients and the skin needs circulation to heal. And if a person is not eating as much or getting the benefit of those, sometimes they're eating and they're not absorbing those nutrients too. So there's that. The main thing is you want to make sure in hospice that if a person starts breaking down, you're getting them on an air mattress quickly. You want to get them on an alternating airflow air mattress to shift underneath the patient because they're not able to be turned and repositioned as frequently, and they can't turn and reposition themselves generally. So we do want to help prevent further skin breakdown where we can. We also want to encourage family members to shift the patient every 1 to 2 hours when possible. In hospice though, if a person is actively dying, we're not going to be shifting that patient as much for comfort's sake. If a person is good and comfortable and you know that they're going to be screaming in pain for an hour after you turn them, you are turning them minimally at end of life, and that's just a fact. But we do want to get them on an air mattress. We do want to make sure that we are teaching how to turn and reposition and getting things like wedges, heel protectors, pillows. A big thing to do when a person is bedbound to prevent pressure ulcers, especially on the heels, is to float. You want to float the heel off of the bed. And when I say float, I mean just that. So this is a pillow, this is the heel. You're going to want that to be off of the pillow and off of the bed where you can put your hand and there is space there and that's not touching the bed. Something that's really challenging to do when you have a person that may be retaining fluid, maybe they're a little bit heavier. Your little thin people are a little bit easier to float, but I will tell you that they are also the people that are going to break down the fastest. Your little skinny, bony people are going to break down the fastest because they don't have the same reserves that a person with a little bit more meat is going to have. I tell you, I see a lot less breakdown in a heavier person than a little tiny person. So really be looking at your little tiny people. Look at everybody. When you're doing a head to toe assessment, you should be looking at the skin on the feet, the bottom, anywhere where there's a pressure area where there's a bony prominence. You want to look at the spine, the shoulder blades, the bottom, the hips, the tailbone for sure. You want to look at behind the ears, the back of the head. You would be surprised, but a wound can develop on the back of the head as well. You can get a wound on the back of your head if you're not moving your head. Also, when you have a patient that's using oxygen, you want to be looking at this behind the ears, because the oxygen can really be irritating and create pressure behind the ears. Another thing you want to do is be looking at those Foley catheters. Any tubing that's on the body, you want to make sure that it is not under the body. You want to make sure that it is free and not pulling tight and not underneath the body, because a person can develop a DTI from tubing that is sitting under their leg, for example, if you get a Foley. Or sometimes we have people who have drains, and we want to make sure that those drains are not under our patients, that they are where they need to be, that they're positioned in the way they need to be positioned. So when we're positioning our patients, we need to make sure that we're looking at where tubes and lines are as well, because that can also create some break in the skin. Especially for your people on hospice, which is what I'm talking about, they will break down so much quicker. 2 to 6 hours it takes for someone to get a serious wound in not moving. So we need to be talking about shifting our patient every 1 to 2 hours. 15 degrees. We just need to shift them at least 15 degrees to get some relief. When we're sitting in bed, when we're laying in bed, sitting in a chair, we shift. We move our bottom if we're uncomfortable. We stand up if we're uncomfortable, but we can lift ourselves up and shift in a chair. And I remember when I was a baby nurse, this is something that they did have us do, to sit in a chair and not move just for 15 minutes. Just for 15 minutes. And it's really hard to not shift your weight and get comfortable even in a 15-minute period. So our patients that are at end of life are not shifting their own weight, and they are dependent on us to do that. And that could be a really minor shift as long as we're doing it every 1 to 2 hours. We do want to keep comfort in mind, and that is really important. When we're talking about wound care, again, we're using things like foam, honey, alginates. We can use something as basic as a wet to dry as well in end of life. I think I came from old school where we did use wet to dries, and I also saw where we stopped using them. So I have a tendency not to, but we don't want to be overly aggressive. We're not going to be doing sharp debridement. And I do want to say, don't be cutting off. I want to say this in any video where I talk about wound care, but don't cut off anything that's hanging. Leave it alone. Don't remove any skin flaps. Don't take any calluses off. Don't cut any necrotic tissue off. Just leave it alone. If you're not delegated and it's not in your scope of practice to do, don't do it. As a nurse, as an aide, in any role, don't do that unless you're trained to do that and you have the authority to do it. And you're under the supervision of a doctor and the doctor says it's okay. You can't just take things off of people. It is not something you want to do in a person that's immune compromised. And people that are dying they are going to be more susceptible to infection because they are not getting the nutrients that they need. Their intake is down. They're not getting the protein. They're not getting their minerals and vitamins. So just think of those things when you're thinking about it. We do still want to prevent infections in wounds in hospice. So we want to make sure that we're doing good, clean technique when we're doing wound care. If a wound is meant to be a sterile technique, we need to be doing sterile technique. If a wound is just aseptic technique, then we need to make sure that we're doing that good and clean and not contaminating other areas. We don't want to pull germs into our wound bed. So be thinking about that. And on hospice, we do use antibiotics for wound infections. Some of the common antibiotics that we use would be things like Cipro, and we use cephalexin. We use Augmentin, less common for wounds, but we do use that sometimes, and it's a little bit of a heavier hitter. We sometimes use Bactrim DS. It's not as common for us to use Bactrim, especially when we're talking about people that may have kidney impairment. So your doctor's going to ask you those questions. We use Macrobid and UTIs just as a sidebar. Some of the things that we are treating, we do have people with PEG tubes. Those can become irritated, so we are sometimes providing wound care to a PEG tube. A person should really be getting a dressing change to that area daily. That's what we do in facilities. In homes, I know it's a little bit different, but we should be assessing any place where there's a drain as well, because that is an opening in the skin and a risk for infection. And then we have people with Plerex or aspiradrains, and those are sterile techniques. Those are sterile techniques. So you want to make sure that you are doing that. And then we have sometimes people who have a port or a pick. And that is also a sterile technique. And those are places that are open in the skin. They're not necessarily wounds, but they're breaks in the skin, and they're things that we should be monitoring for signs and symptoms of infection, and that we should be using the proper technique when we're changing those bandages. So we do have a lot of dressing changes in hospice. Most of them are for comfort. And we do sometimes have people that are on TPN or they're on certain medications. We've had patients on milrinone, patients not necessarily on IV fluids because you need to be able to manage those and monitor those, but I've seen patients on IV antibiotics in the home depending on what type of situation they are with their hospice. Different companies have different open access type programs that allow different types of treatments that may be more aggressive for a short time. So keep in mind when you're doing hospice too that you might see people with a pick, a port, or a drain. You're going to come into those things sometimes, and catheters, absolutely catheters. So just be aware that anything that's going into the body from the outside is at risk to create an infection. So be mindful of using sterile technique when you're changing a pick or a port or a catheter or an Aspira or a Plerex drain. Those are the types of things that we're going to be doing sterile. And yes, it is sterile, so you want to have extras in case you contaminate, because you do not want to be going in more than once with a Huber needle. You do not want to be, if you drop something, if you contaminate something, you need to open up a new package and start over. Sorry, but that's the way it is. I have been in a situation where I was completely sterile, and if you contaminate, you just have to apologize and start over. Unfortunately, that's just the way it is. We do not want to give our people infections. Even in hospice, we do not want to risk an infection. We don't want someone to have sepsis. We don't want them to be more uncomfortable. We want them to have a peaceful, comfortable dying process. And part of that is avoiding infections. So that is my spiel on wounds for hospice care. Do you have any questions about that? What are some types of wounds that you've seen in hospice? I've seen some really big ones, and I will tell you that we do still treat. We do still treat in hospice. Even if we're not trying to be aggressive, we are still doing nursing care and treating the whole patient. So I have seen some really big wounds in hospice as well that came a long way before the patient passed, and it's still something that we look forward to in hospice, is seeing a wound heal. So I'd love to hear about your experiences in the comments or anything that you would be curious to know about. And if you like what you see here, like, subscribe, follow, and share. And I thank you so much for watching. Bye bye.